Hey, Sunil. Can you hear me, Sunil? Hello, hello. Can you hear me, Sunil? Can you hear me, Sunil? Hello, hello. Testing 1, 2. Can you hear me, Sunil? Can you hear me, Sunil? Can you hear me, Sunil?
Assalamu alaikum, مساء الخير. Good evening, everybody. My name is Ibrahim Sbeih, and we are transmitting live from the Farah Medical Campus here in Amman, Jordan. And the backdrop is Farah Campus, made of two sections, the Mother and Child Hospital and the General Farah Hospital, which was established by late Dr. Kimani. Dr. Kilani was born in Naslet in Palestine, as you can see here in this picture. He migrated to Jordan after the 1948 war in Palestine, and he studied at the Kulliyah al-Ilmiya al-Islamiyya, and then he went to Germany and United Kingdom, London, where he attained his degree in obstetrics and gynecology. Came back to Jordan and established the first Jordanian Society for Fertility and Genetics, which was also the first society of its kind in the Arab world and the Middle East. He was immediately known for the IVF babies and testicle babies. Jordan was country number 7 in the world to do so. So he really acclaimed a position that no one could take it from him. He received recognition from late King Hussein and from King Abdullah, and one of his colleagues, who took the Nobel Prize for his work at the Institute. They were best buddies, they were friends. That's how he was, that's the position in the world he attained. We've lost Dr. Kilani a couple of days ago, and I cannot forget this view when the ambulance taking his body for his grave, where the nurses and the staff just joined just to say goodbye. You can order people to stand there, but you cannot ask them to weep and cry. That was my most touching moment. I may ask you to stand for 1 minute of silence for Dr. Zaid Kilani. نقرأ الفاتحة. Dr. Kilani was a friend and a brother, and he wanted this hospital to be a minaret of science. He wanted it to be the house for happiness and for distribution of knowledge. And I want you all to support us to do so, to make Farah Hospital the minaret of science and happiness. I'll proceed with the lecture. It's a personal series of 29 cases of cholesterol granuloma of the petrous bone. This is one of the largest series in the world, which I have just been lucky to have this number. Again, we'll discuss the clinical, radiological, operative, and pathological correlation. So, as we are talking about pathology and the temporal bone, let's just go through quickly the anatomy of the temporal bone. To me, and to many others, temporal bone is the most sophisticated bone in our body. No other bone is with this kind of sophistication. So you can see here the temporal bone, sphenoid bone, and occipital bone. But the dangerous one, the difficult one, is the temporal bone. Here's the view from external part, and this is the view from internal of the left temporal bone. And one speak about parts of the temporal bone: the squamous part, the mastoid part, the zygomatic part, the tympanic part, the stylomastoid part, and the petrous part. So 6 parts. And if you add the 3 ossicles, the medius, incus, and stapes, then we have 9 parts of the temporal bone. If you look from inside, this is the inside of the skull, and look at here, this is called the pyramid of the petrous. So this is all petrous, but this is the apex, or the pyramid. And it is a real pyramid with superior surface, medial posterior surface, and lateral surface. You can see here foramen ovale, you can see here foramen lacerum, ovale lacerum, and you can see here the jugular foramen, the intended jugatus, full of structures here at the apex of the temporal bone. Close-up view, I took this with my camera from my hospital, my cadaveric skull that I have in my clinic, and you can see the petrous bone from below. You can see the apex. Here is the carotid canal. It passes inside and goes to foramen lacerum. Carotid canal, foramen lacerum. And just posterior here is the jugular foramen. So this part is very, very dangerous. Look from inside again. This is petrous apex. Again, this is the tip of the petrous. This is the tertius, the lower cranial nerves, the trigeminal nerve, the sixth nerve. Petrous apex with severe petrosal sinus, actual petrosal sinus. Internal determinatus with 7-8 nerve, trigeminal nerve. And here inside the bone, if you dig, you will find the petrous carotid artery. From inside of the temporal bone, this is the petrous bone. You can see the interdeginatus, and you can see here, as in here, the sigmoid sinus going into the jugular tubercle. Again, looking from the top, axial cut, petrous bone on the left. This is the interdeginatus. This is the cochleum. These are the semicircular canals, mastoid antrum, mastoid nerve cells, and the epididymis into the middle ear, station 2. So anything in this area is real danger. The cut again in the axial cut, external ear, take you to the tympanic membrane, medius, incus, and stapes, the semicircular canals, the cochlea, the station 2, petrous apex. Coronal view, external ear, tympanic membrane, medius, incus, stapes, semicircular canals, carotid going into petrous apex here. The external surface of the temporal bone, as you can see, as I said, made of the squamous part, the zygomatic part, the mastoid part, the tympanic parts. With the anatomy here is very important. The McQueen triangle and the Hill's spine are very important for any ENT or neurosurgical resident. This is a very beautiful cut view made by Mario Sana from Italy, showing you this sophisticated anatomical relationship of the temporal bone, how the carotid arteries go in front. This is the sigmoid sinus, jugular foramen. These are the 5 parts of the facial nerve, ending with the facial coming out here at the stylomastoid foramen. If you look here, you can see the petrous part of the carotid within the petrous bone, here and here. Again, you can see it here, here, and here. Carotid itself has a very intimate relation with the petrous bone. It comes here from the internal carotid canal, or carotid canal from the cervix, the neck, and then goes petrous part, and then the paraclavian part, and then the part within the cavernous sinus. So this is the petrous part, the paraclavian part, and the part within the cavernous sinus. This should be essential knowledge for any neurosurgical resident. But in the Arab world, in Asia, this is not important anatomy. They just been taught about doing silly things like just their horse, or as I said, taking a discount. But this anatomy, they don't know about it. This is looking at the skull from below. This is carotid going into the internal canal, going through the petrous part. and the same here. And here you can appreciate, this is where the carotid gets into the skull at the internal, at the carotid canal. Here is the petrous part. And here you can follow it up going into the skull. This is the petrous part. Carotid going in, this is petrous part, paraclival part, and the cavernous part. So we know now the temporal bone. What about the cholesterol granuloma? What is a cholesterol granuloma? It is a granuloma, granulation tissue, formed in the petrous bone, especially in the apex. How does it happen? Two theories. One theory related to obstruction, something causes obstruction of the air cells, secretions, inflammation, whatever. And the other one, that there is no obstruction, but the bone marrow is exposed to the air inside these air cells. So the obstruction theory, something causes obstruction, the air is absorbed, the pressure is less, there is mucosal edema, some vessels rupture, they cause hemorrhage breakdown, and cholesterol crystals initiate a foreign body reaction and form a granuloma. They found that 12% of cases with these cholesterol granuloma, they have history of chronic otitis media. Does that mean that otitis media is a cause of the cholesterol granuloma? The answer is no, but it is an observation. Because cholesterol granuloma can occur without any previous history of infection. I'll come to that. The second one is the exposed marrow theory. Nothing related to obstruction, but this is extra aeration or pneumatization. And mind you that the petrous apex is pneumatized in 9 to 30% of cases and non-pneumatized in this high percentage of cases. And it is just filled with bone marrow. So you can see here difference between this side and this side. This is bone marrow, this is aeration. Here both are filled with bone marrow. Bone marrow here, some aeration here. So various variations. Look at this, fully aerated petrous apex. Some aeration, no aeration whatsoever. So people speak about grade 0 pneumatization, where the petrous apex is not pneumatized at all, and grade 3 pneumatization, where it is fully pneumatized. So when these air cells having bone marrow are exposed to the air, they will get hemorrhage. Hemorrhage will initiate a foreign body reaction, and you get the granuloma. So this is the theory of the exposed marrow theory. So the names, the correct name is cholesterol granuloma. There are old names that are now completely omitted. Cholesterol cyst, chocolate cyst, blue drum membrane, etc., etc. So what is cholesterol granuloma? It is an intraosseous cyst surrounded by thick fibrous capsule, but it is a benign lesion that can behave aggressively. Very rare, 1 case per 2 million population. And you can see here the relationship with the carotid. It is surrounding the carotid because the carotid is in the petrous apex. Now again, here is the coronal cut, the external ear, the tympanic membrane, the malleus, incus, and stapes, semicervical canals, and you get the granuloma here in the apex. They love the apex of the temporal bone, or in this case, in the sagittal cuts, or in this case here in the sagittal cuts, and that one is coronal cuts. It can be bilateral, very rare, but it can happen. So what is the histology of these cases? We asked Dr. Hassan Pasha to us, what is the histological features of these lesions?
We have 4 cases altogether, cholesterol granuloma, me and Dr. Ibrahim Sbih together. I have 1 gross specimens, and you can see grossly it looks like brownish, tan brown, and probably this is because of the cholesterol, and it's not well defined as it's in this case. This is the only case that I have a gross specimen of it. And it's darky, probably there's some blood also in the Microscopically, this is very typical. You see this is a meningothelial lining, And these are cholesterol clefts. And this is bony tissue. And there are many foreign body giant cells with fibrosis filled with chronic inflammation. You can see this is typical of cholesterol cleft. That's why it's called cholesterol granuloma. And these are many giant cells surrounding cholesterol, because cholesterol is considered by our body as foreign body. And multiple or many areas of inflammation and fibrosis, and probably this is what caused the expanding mass and why it is really adherent to the surrounding tissue. You can see here, these are all forming histiocytes, and this is foreign body giant cell reaction in this region. This is again very big cholesterol cleft, and these all surrounding by considered as foreign body. These are foreign body giant cells, many of them here. And you can see the inflammation, the foreign body giant cells, lymphocytes, and many plasma cells, many plasma cells. This is a very antigenic mass. Again, you can see, I took pictures from different cases that we have cholesterol clips together, forming bigger clips. And this is very antigenic, and that's why it surrounds by inflammation. This is CD68 indicating how much the amount of histiocytes there are there. There are many histiocytes are there. This is actually epithelial membrane antigen, because they are attached to or near the meningeal membranes in the vitreous area. So it's epithelial membrane antigen positive. But this is strangely, this is beta catenin, and this has a membranous pattern of staining in this area. And this is beta catenin and has nuclear pattern of staining in the meningeal tissue attached to it. This is not reported in the literature. I'm not sure whether this is really significant or not, because I only did it in one case. I didn't do it in the other two cases because I started to do more and more staining. And if we have more cases, this could be really significant, because this is a change that can occur in meningeal tissue, mimicking craniopharyngioma or other tissue that has beta catenin nuclear positivity. So this is in general the histology of cholesterol granuloma.
Thank you, sir. So as we said, it is a granuloma which is related to the reaction that you have due to hemorrhage for whatever reason. Does it occur only in the temporal bone? No. Actually, it can happen in many parts of your body, but it loves the temporal bone. And the temporal bone, it can affect the mastoid, the middle ear, or the apex. Paper from the United States, 2012, shows that it can affect the sinuses, frontal sinus, more than the maxillary, more than the sphenoid. So they love the head in general. Here is a frontal sinus. You can see the granuloma, cholesterol granuloma. Here is cholesterol granuloma within the sphenoid sinus. Again, you can see here maxillary sinus, orbits. You can see different patients, different pathologies. Nasal septum, both right and left. Mandible.
What is the specific symptom?
Pain, destruction, loose tooth, etc. Headache. So they can come with various presentation. Can affect the lips. It can affect the intestinal. Can affect the lungs, can affect the breast.
Is it slowly growing?
Slowly growing. Yeah, slowly. It is a benign lesion, but when it comes to the skull base, they become very virulent and difficult to eradicate. Abdominal wall. This is the view through the laparoscope. Pancreas, kidneys, and as I said, they love temporal bone, they love the skull, so they can happen anywhere within the temporal bone. Look at this here, in the apex extending to the posterior fossa, extending anteriorly to the ethmoid and sphenoid sinuses. External ear, this is I don't know whether we have any ENT colleagues here today. You see it a lot, yes? Yes, but you see the blue drum thing. External ear, in addition to the drum, you can get it in the external ear. Inner ear, of course. Again, the blue drum. Temporal bone, as you said, in any parts of the temporal bone. Here it is affecting the mastoid part. Again, here affecting the apex, and this is the mastoidectomy that people do for that. But we forget that it can also affect the brain. Cerebral cholesterol granuloma being reported from Brazil, 2007. And this is again case of cerebral cholesterol granuloma. So how do they present? I'm putting here the summary of my cases, how they present. Again, the presentation depends on the size and the location, but the main presentation is cochlear, hearing loss, tinnitus, etc. Vestibular, vertigo, dizziness, headaches is very common. Facial nerve affection, double vision due to reducing nerve and other cranial nerve palsy. If you go into the cavernous sinus, facial numbness, discharging ear, lower cranial nerve palsies. So remember this, hearing loss is the commonest presentation, followed by vertigo and followed by headache. Any other unusual presentation? Yes, they can present as Meniere's disease. So the patient has been complaining of Meniere's disease, but then he was found to have this tumor. And again here, the navigation system, I think navigation people are here today. Yes, it's very useful in these cases. They can present with nerve pulse and abducent nerve palsy like this. This is a beautiful view of how the abducent comes from the pons and goes up to the Dorello's canal. They can also come with facial weakness, and when you come to facial weakness, you have to grade the facial weakness. And this grading for facial weakness is House Brackman classification in relation to House, who was the first ENT surgeon to do this House Institute for Research in the United States. William House, he died in 2012, but he remained very active till his last days, supervising paper publications and scientific paper publications. Life never ends. You have to continue doing publication. And I'm proud to say that I have 47 publications. I say I'm not doing well. Dr. Gerald Brackman was a friend of Jordan. He was the private physician for King Hussein, and he's a friend of mine. So House Brackman grading, they do this, the gross appearance of the face, what happens at rest, what happens at motion. So they did the grading. So grade 1 is like asymmetry of the face, and this could be normal. This could be sexy again, to have a slight weakness. Actually, Mona Lisa is having this grade 1 facial weakness. And this is Star Trek saying, are you sure? Grade 2, as I said, at rest and on movement of the upper face and lower face. That's what we get. Grade 3, grade 4, grade 5, and grade 6. Full, complete facial palsy. So you cannot speak about facial weakness per se. You have to give a grading. If you don't give a grading, it means that you are very much backward in science and knowledge. Another grade 6. That takes me really to a book called Greenberg book, which is called handbook. Handbook means what? Something you put in your pocket or in the pocket of your white coat. That when you are doing ground, you open it to look at things or the night of the exam. Some mediocre surgeons are using this as their textbook. And I hope Greenberg is listening, and those mediocre surgeons are listening. Greenberg is a handbook. It should not be treated as a textbook. Radiology, of cholesterol granuloma. If you do CT, you'll find destruction. And that's what characterizes the cholesterol granuloma. MRI, you see these lesions, various shapes and sizes. So what is the differential diagnosis? And why should we bother about differential diagnosis? Again, mediocre surgeons don't want to know this. They just want to know one pathology and that's it. They want just to look at this handbook. They don't want to go deeper. It is hardboiled. You're asking for too much. They don't want to give anything except doing a bed hole or putting screws in the backs of the patients. So our lesions, yes.
And the shunt.
Yes, and the shunt, of course. And gamma ray. There are lesions called leave me alone. Don't touch me, please. I'm innocent, I'm benign. And there are lesions that say, please don't leave me. Do something for me. So let's look. How deep is the differential diagnosis in this area? If we look at the petrous apex, the commonest lesion is cholesterol granuloma. Cholesteatoma, which is totally different from cholesterol granuloma. Cholesterol granuloma is one side, cholesteatoma is the other. They are not the same lesion. People still think of them as the one lesion. So commonest is cholesterol granuloma, 60%, followed by cholesteatoma, followed by chondromas, etc. But there are other lesions, inflammatory lesions, tumors, vascular lesions, and invasion. You should know this. You, mediocre residents and neurosurgeons, should know this. This is, leave me alone. Don't touch me. As we have said, the difference between pneumatization of two apexes. This is aerated, this is not. This is bone marrow. So this is normal. I have plenty of these cases coming to my clinic for surgery. Because the radiologist does not diagnose them well, and the whoever saw them refer them for surgery. They don't need surgery. So it is a fatty marrow. Apex with marrow, apex with no marrow. Difference in the same patient. How can you differentiate between cholesterol granuloma and asymmetry fatty marrow? Very easy, looking at T1 and T2. So there is a way of differentiation. Again, those mediocre people don't want to know. Or it's a simple effusion. Needs no treatment, leave me alone. No destruction, just some expansion, but no destruction. Simple diffusion. Trapped fluid in the petrous apex. There's sometimes some inflammation, apical petrositis. This needs antibiotics. Rarely it needs drainage. Mucocele, usually antibiotics, rarely needs drainage.
Why antibiotics? Is this bacterial?
Yes, bacteria most likely. Cholesteatoma is different from cholesterol granuloma. I just choose to put this one for you, but it contains the cholesteatoma and the cholesterol granuloma. This is faint, this is tense. And you can differentiate between cholesterol granuloma and cholesteatoma by doing restriction, the diffusion technique. Of course, the differentiation is too big, so I just summarize it as such. Encephalocele, there's a defect of the bone and the dura, and the brain in CSF goes down into the trigeminal area. If it is symptomatic, it needs treatment. If not, you don't. Schwannomas, whether oculomotor nerve, or trochlear nerve, trigeminal nerve, inducent nerve, facial nerve, vestibular nerve, foramen, schwannoma lower cranial nerves, vagus nerve, accessory hypoglossal, petroclival angiomas, they are in the same area, so they can actually cause this problem. Chondromas, metastasis, this here is fusion of the PET and CT. You can see the metastasis there. The glomus jugulare very much looks like the cholesterol granuloma that we have seen. It is the most dreadful kind of tumors you face. Aneurysm of the petrous carotid. Very much. They do exist. These are real cases. Jugular bulb diverticulation, jugular bulb variations. There's so-called low jugular bulb, there's so-called high jugular bulb with diverticulation. So variations in the jugular bulb. Rhabdomyosarcoma, the petrous. Endolymphatic sac. I'm lucky I have 2 cases in my life. They're extremely rare. Plasmacytoma, whether single or multiple myeloma. Langerhans histiocytosis, they love that area and they cause destruction like a cholestatic myeloma. Nasopharyngeal carcinoma extending into petrous apex. So the list goes on and on, and there is a way of differentiation between epidermoid, lipoma, and aneurysmal. For those people who want to know, for those people who want to learn, for those people intelligent enough not to use the so-called Greenberg handbook. Please. Dr. Adasi, oncologist.
So there really isn't a better way of celebrating the legacy of the great Dr. Kilani than to have such a highbrow, multidisciplinary, clinical, pathological, scientific discussion with the backdrop of the 2 towers of Farah Medical Campus and the presence of his 2 sons, Sanad and Karam. This is really what we continue to maintain on a weekly basis on this research and on a daily basis in our practice. What is a medical oncologist here talking about cholesterol granuloma? It's exactly because of this. The differential is so huge, and everything would look like a cholesterol granuloma if you want to look at things on the surface. But the implications of this extensive differential diagnosis is huge. Chondrosarcoma, and sarcoma is not one disease, of course. Chondrosarcoma, the real treatment is optimal surgery because chemotherapy doesn't work, radiotherapy doesn't work. Rhabdomyosarcoma in this region, surgery and multi-agent chemotherapy would be the cornerstone of this. To go back, nasopharyngeal carcinoma extending to this area is important because the treatment is multi-agent chemotherapy and radiotherapy with a concomitant part. LCH has not to be missed in this place because it would masquerade as a lot of things, and plasmacytoma is not something to be missed. If there is a lesion that you really have to make sure that this is a solitary plasmacytoma, the treatment of which is clearly radiotherapy, and unless it's a part of multiple myeloma, these patients would really need SPEPs and UPEPs and bone marrow examinations. I can't emphasize enough the importance of not missing metastases. I've just came up from my clinic because having spent an hour explaining to the patient why I need to do the prostate examination to explain his shoulder pain. For him, the idea was prostate. And this patient turned out actually to have metastatic prostate cancer. Prostate cancer usually does not involve this area, though. In a smoker, it would be more likely lung. In a woman, it would be more likely breast, and thyroid should not be missed in either. The main thing is a thorough examination. Now, schwannomas, the mainstay would be surgery, optimal surgery, radiotherapy as an adjuvant if that is needed. The differential diagnosis is really tremendous, and these are actual cases. These are not theoretical exercises. Thank you for your time.
So what is the treatment of these cholesterol granuloma? Basically, if they are asymptomatic, just leave them, just follow them up. All in all, treatment depends on the location, the size, is there any hearing loss, complications, etc., etc. So asymptomatic, leave alone, don't operate, just follow up yearly. If they are symptomatic, then you go for surgical treatment. What is surgical treatment? It's either open surgery or endoscopy. We are living in an era of endoscopy, and endoscopy is going to take over the open surgery. If I am a resident now, I would go for endoscopy training. It is the future of neurosurgery. There are approaches for the ENT, there are approaches for the surgeon, different approaches. I'm not going to dwell on that. But basically, again, this picture from Sana from Italy. He's the giant of giants of temporal bone surgery and anatomy and research. So these are the approaches. You can go suboccipital from the back. You can go transmuscular, labyrinthine through the labyrinth. You destroy the labyrinth if it is already destroyed. Or you can go transmuscular intraoral, underneath the labyrinth. The labyrinthine, so you go underneath. Or you can go from above, transtemporal, or you can go transfemoral. Whether open surgery, microscopic surgery, or endoscopic surgery. So these are the approaches. Again, suboccipital. This is retrolabyrinthine because you go behind the labyrinth. This is translabyrinthine, and so on. The idea is to evacuate, to take it out, and obliterate the cavity by putting fat or muscle. I prefer muscle. I don't like fat that much. This is the middle fossa approach. Again, here it needs knowledge of anatomy that is not applicable for mediocre surgeons and business who read the so-called Greenberg handbook. And they have put a tube, the drainage tube for that. Petrus Ellis cholesterol granuloma paper authored by Dr. Al-Mifti, a giant of giants of spinal surgery. He put this case through the middle fossa and removed the whole thing and put a muscle graft. Middle fossa approach from Japan. You want to go to the petrous apex. This is here anterior, this is posterior, this is lateral. And when you drill it there, you will find everything you want. Anterior transpetrosal, the so-called Kawase triangle, it can be used. The infralabyrinthine approach as such from Turkey, 2014. So surgery is still one of the main pillars of treatment. But it's not for simple cases. Simple cases you go for endoscopy. Large cases like the ones I'm going to show you, you need open surgery. In 2019, things have changed. You have to accept defeat mediocre surgeons and accept that still the surgery is being practiced, but you don't know about it. So retrolabyrinthine or translabyrinthine, posterior petrosal approach or pre-sigmoid approach, like this on the left side, incision. This is middle fossa, this is posterior fossa. So this is the sigmoid sinus, posterior fossa dura, middle fossa dura. Why am I showing you this? Because you are going to see it in one of our surgeries. So I'm preparing you with the anatomy so that you will go with us regarding this. So this is the patient now. These are the semicircular canals. The drilling is done. So here is the drilling with the semicircular canals. Okay. So endoscopy, again, one of the main pillars of treatment. But you will see that they are treating small cases that are not really related much to the carotid artery. Large cases, endoscopists will tell you they need open microscopic surgery. This is recent, this is 2019, for the ignorant, mediocre surgeons to understand. A group of famous endoscopists, Charles Steele from Australia, there he is on a trip here, Amin Kassan, and Schneiderman from Pittsburgh, and they moved to New York. Paul Gardner, Michael Gabb from Germany, Theodore Schwarz in New York. These are famous surgeons that established the endoscope approaches. So it's beautiful. They go through the sphenoid and they go to the petrous apex. Look at this, sphenoid sinus, this is it. They go through the sphenoid sinus into the cholesterol granuloma. A paper, again by Schneiderman and his group, 2012, they classified this. They said, listen, if the cholesterol granuloma is related to the paraclital, this is for us, endoscopists. So they can go this way and take it out. If it is here, the petrous, it is midway between open surgery and endoscopy. It is not here, it is here. So it can be done open surgery or endoscopy. This, where it is between the petrous and the cervical, this is for open surgery. These are the recommendations of the endoscopists. And this is a recent paper for those just to sit back and listen. Maybe they will learn something. The use of the navigation is important. And this is the pedicle flap. After they have put the drainage tube, it failed, so they put the pedicle flap to close the cavity. The anatomy of the Eden canal came strongly, and it is so many papers published about that. Started 2007 and not ending 2019 about the anatomy of the Eden canal in relation to the pterygoid fossa, pterygopalatine fossa. And this paper also 2007 by the same group, saying this is the prime time for endoscopy. Look at this beautiful view showing you the anatomy and the tube on the road to the petrosaurus from this finger. Again here, from Turkey, 2009, you can see the tube. Even for recurrent, you can go and remove the material and put a drainage tube. My personal series, this crossover, the second was really lucky to have this large number. It is one of the largest in the history of the literature. I did not have any cases in the first 5 years in Jordan. I came back 85 and 90, I did not have a single case. But then 90 to 2019, 30 years, I had 29 patients, males, more than females. Lucky for us, what can we do? The youngest is 26, the oldest is 70, the average is this, 40, 50. And this is some of the cases of mine. These are my cases, not taken from books like mediocre surgeons do. They go into books and they just say that this is their work. It is not their work. Everybody knows that. You have to present your cases, not the others. I hope the mediocre surgeons are listening. So I use so many approaches. I'm not a prisoner of one approach. Retrosigmoid approach, middle fossa approach, pre-sigmoid approach, combined approaches, because you have to be versatile. If you just know one approach, you will fail. And we have long follow-ups. Results, mortality none. I had no mortality in these cases. I had recurrence in 3. Of course, I had some morbidity, dehiscence of 1, subfistula, worse hearing, permanent worse facial, and no vascular injury. Some of the cases, 65-year-old male patient who had chronic otitis media since childhood. He had many surgeries on his ear, and he presented with this. You can see the fluid level and the destruction. So he had facial weakness. This is the scar of the mastoidectomy he had in the past. He had facial weakness on presentation. I did surgery for him. This is before surgery, this is after. That was back in 2003. Disappeared for 6 years, which is not the case because you have to follow them 6 months or a year. He came back with sick nerve palsy in addition to the facial weakness. So he had this huge, giant kind of tumor causing massive destruction. I did surgery for him together with Dr. Tarek Face. Both did his own job, and we did a very good job in removing this is the fat graft and the muscle graft. Of course, his facial weakness was worse immediately post-op. For them, over the years, 2011, no recurrence, 2012, his facial weakness very much improved. Thank you.
Is the recurrence usual?
that are common to care. If you have not done your job well, yes. So excision is the main thing. 2013, no recurrence whatsoever. Actually, Ahmed and Musab, my secretaries, they phone him and say, oh, you have forgot to come this year, please do MRI and send it to us. So 2015, 2016, you have to keep record of your patients. Facial weakness is completely done, which is unusual. 2017, 2018. This year, Ahmed called his son and said, yes, I'll send you the pictures. They didn't, but he's good. Another case, MRI of this man is 70. But look at this, very much like any tumor in the cerebellum triangle. Look at the destruction there. Surgery, and the man is doing extremely well. Third patient from Syria, 46-year-old man, and he's a diver from Latvia. He goes underneath water, digging, going very deep as a diver, and he developed this. And it is known that some of the professions are more prone to cholesterol granuloma, like diving. It has nothing to do with your cholesterol level. So here you are. And this is conservative, and this is follow-up. I've lost follow-up since 2011. You know the situation in Syria, I don't know how it's doing. Some videos, and we'll finish with that. We have about 10 minutes. Videos are different cases. I just want you to have the taste and the picture of how they look like and what should we do about it. And maybe if some of the mediocre surgeons are listening, maybe they will learn something. So here we are. This is retracting the cerebellum this way. This is midline. And you can see this is the capsule. It is well capsulated, but it is adherent. So cauterization. And once you open it, you get like that. You'll get some of this oil-like fluid full of cholesterol. Look at this. It's not enough just to drain them. You have to remove the capsule. Whether endoscopic or open, removal of the capsule and mobilization is much better than just the drainage. And then you go and try to dissect it off the surrounding structures, like acoustic neuroma, like anything. So sharp dissection, because it's very adherent. Okay, we'll stop this and do the next one, just to know what is cholesterol. Again, here we are on the right side, midline is there, this is the right side, cerebellum is retracted this way, and this is the huge lesion. Again, you suck what is fluid inside the cholesterol fluid, but that is not enough. Mediocre surgeons would do that, like they do with the glioma, with the meningioma. They just take a specimen, they say decompression, which is a very misleading word, and send the patient for radiotherapy or whatever. Here you have to remove it.
Oh, the capsule.
Yes, this is a capsule, so we have to remove it. And with the capsule, you will find some of the bones of the temporal bone that are being included in the lesion. This is dangerous. You are here dealing with the carotid, with the basilar, with the pica, with the ica, with the facial nerve, with the vagus nerve, etc., etc. So it is not a job for Speedy Gonzalez, and I hope some of the Speedy Gonzalez's are listening. Maybe they will learn something. Look at this thick tumor. This will not go with just a drainage. You have to remove it. So surgery is still one of the mainstays for these large tumors. Small tumors, yes, I would refer them for endoscopy. But larger tumors like this, you have to do. This is 2019 mediocre surgeons. Please listen.
So that's all capsule.
Yes, it's a tumor. It's just a tumor. Leave it there and it will come back. That's why I had very little recurrence. 3 out of 29 is very modest recurrence, because I do this, I excise the lesion, and not just to drain it, and finish within 1 hour and say, oh, I'm a speedy Gonzalez surgeon. And they do this with the glamour, 1 hour surgery, and they leave. So here we are, just going. Look at the fluid inside. Some people say, look, I have decompressed the brainstem. Nonsense. You're lying to people. You're lying to your residents. You're lying to yourself. You are a mediocre surgeon. If you do this, it's not enough. You have to take the whole thing out. I just want you to follow and see the tissues that we remove. It's a huge tissue, a mass of tissue, extensive mass. Look at this. All this. This is a tumor. It is a tumor, actually. It's so-called the granuloma. It behaves like a tumor. And you should treat it as such. So huge tissues that needs to be removed. As I said, I made my job in life to expose the mediocre surgeons and expose their illegal practices, which they lie to people about. I have no problem with that at all. Just to learn, to listen, أن يقفوا عن هذه الأعمال الشريرة, stop the devil. Maybe this is good for human beings and for humanity as in general. But to continue lying to people, lying to residents, and lying to themselves about the basic principles of surgery and basic principles of reading, like reading Greenberg. Jesus Christ, Greenberg is a handbook. It is not a textbook. Yet people are told that this, if you read this, you'll be a good neurosurgeon. Never. Greenberg himself says that this is not book, but it's a fat notebook that you almost cannot put it in your bucket. Okay, we'll take the last one. Practices of minimal surgery, evacuating the flow. This is a pre-signal approach, like the ones you have seen in the anatomy. This is the middle fossa here. This is here, the middle fossa dura. This is here, posterior fossa dura. So you drill the bone. You remove the remnants of bone because it is usually destroyed. So this is the dura of the middle fossa. Here we're going into the inner ear. Here you can see the facial canal, facial nerve. You go above it, you go below it. You go to the cochlea, you go to the labyrinth, so that you can take the tumor out. This cannot be done by medical surgeons. So they prefer to puncture it and then say, we have done a good job. We have decompressed the brain. If the hearing is lost, this is what we do. So you do this if the hearing is lost. Of course, if the hearing is preserved, destroyed by the tumor. Exactly. Cochlea has been destroyed. Here we are drilling the semicircular canals. So that's because the labyrinth is completely destroyed. So you just take that out. Yes. And you will see it now as we go. Here you would find the cochlea, and anterior to that you will find the carotid artery. Again, knowledge of anatomy, which the notebook of Greenberg does not supply. It is something that we just memorize. The branches of the carotid artery in the cavernous sinus are 1, 2, 3, 4. They're not knowing anything about the proper anatomy and physiology. Reading Greenberg is one of the main reasons of retardation of neurosurgery in this part of the world. And I hope Greenberg would come out and say, yes, look at this facial nerve, cochlea is gone, we do hemostasis and we just put muscle and fats. As you can see, the muscle and fat packing and the closure, okay. Finished just in time, less than 1 hour. In conclusion, surgical approach is influenced by your experience, by the size, by whether or not you have hearing, by whether or not you have facial palsy, and the location in relation to jugular bulb and the artery. The best management is excision and cavity obliteration, whether open surgery or endoscopy. Again, endoscopy is the future of neurosurgery. Fenestration and drainage is not enough. And if you have lost your hearing, very rarely, if impossible to get it back. If you have facial weakness before surgery, almost impossible to get it back, but we were lucky in our patient to get it back. With this, I finish. And once again, remind you of the legacy of late Dr. Zaid Kilani. He wanted this to be a minute of science and happiness. Let's all put our efforts together to make it so. Thank you very much. Any questions or comments? So right now, Madam. Microphone.
I want to say something about how to approach the cholesterol from the radiological point of view. The first thing, which is very important, you have to differentiate from the mucosid. Sometimes mucosid, if it's proteinaceous material, it's patently one, which is very difficult in this situation to differentiate. You have to go to T280 to look for hemosiderin and to do a FLAIR sequence, because in FLAIR sequence, it can suppress in the mucosid, but does not suppress in the cholesterol granule. The second thing is, if there is asymmetries, pneumatization or one hour, you have to do fat sap. Fat sap, it's suppressed in 2 cases, in one model and in asymmetry of pneumatization. The third thing is how to differentiate between cholesterol granuloma and cholesteatoma or epidermal. You have to go to diffusion. In diffusion, there's a restriction of epidermoid and cholesteatoma, but not in the cholesterol granuloma. The last one is the bone tumors. The bone tumors, you have to go to CT scan looking for calcification, because cholesterol granuloma does not calcify and does not enhance. Sometimes it enhances in the peripheral part. And the last one is infection. If there is petrositis, if it's in phlegmon, it enhances in central and peripheral. And if there is an abscess, you have to go to diffusion. There is a restriction of the abscess. Thank you.
Any other questions or comments? Please, Dr. Hassan, he's a pathologist from Jordan Hospital.
Like Dr. Ibrahim mentioned, these are extremely rare. I haven't seen one in so many years. But the rare things come in pairs, actually. And in the last couple of months, I saw 2 cases. One of them was in the frontal lobe, but this patient also had a lesion in the frontal sinus. And I think that was an extension from it. And they thought it was a fungal infection. I did silver stain, it was completely negative, but it was typical cholesterol gland. The other one was in the mediastinum, which is extremely rare. And it was replacing the thymus gland. And it had also osseous metaplasia, which is also extremely rare. Thank you.
Thank you very much. Any more comments or questions? If not, then thank you very much for coming. We'll meet next Wednesday. Remember, we have to maintain the legacy of late Dr. Zaid Kilani. Thank you very much.
Hello. Okay. Yes. I just have a comment. I'd like to say hello and just thank you. Yeah, please.
Thank you.
Yes. Yeah, just a few words, okay? Hi, Dr. Sabaya, can you hear me
Hello.
okay?
Yes, I can. Thank you.
Okay, thank you very much. Excellent. How do you like your new auditorium?
It's beautiful. It's open, so you feel like you are sitting in the outdoors. It gives you this feeling of liberty, of freedom, yet it is secluded. It's beautiful.
Wow.
Absolutely beautiful.
Wow, that's great. Well, we have a med student from Mozambique, Musindo. Do you want to meet Dr. Sabaya? Go ahead, Musindo.
Yes, I'm here.
Could you please
Hello.
introduce yourself to Dr. Sabaya?
Okay, I am Augusto Musindo from Mozambique. I am resident of third year in Maputo Central Hospital.
Pleasure to meet you.
Yeah, that's where Dr. Kazadi is from. You probably know
Yes.
him, right?
Yes, of course.
Okay, what's the show going to be for next week?
I thought we'll put my series of hemangioblastoma of the brainstem.
Okay,
So it is not in the cerebellum, it is inside the brainstem. These are very dangerous collection of cases which will be next week.
okay, we look forward to that. So we'll see you next week, Doc. Thank you very much.
Thank you very much. Thank you all. Bye-bye.
Bye-bye. Okay, Musindo.
Yes,
Okay, so what year? You're a second year resident, right?
third years, third.
Oh, third year.
Yes.
It's a small program, right? One resident per year.
Hello.
Yeah, can you hear me?
I can hear you.
Okay, how many residents do you have? Two in each class?
We are now 6 residents.
Oh, okay. Very good.
Six.
Okay, very good. Okay, then maybe I'll see you Friday.
Okay, I think I will see you.
Okay.
You will see me.
Okay, great. We'll see you then.
Thank you.
Bye-bye.
Goodbye.